Okay, so this is our talk on CNS infections. All right, so our first case is a comparative case. This is versus that. You may recognize this one from my casebook, but it's high yield enough that I'm going to mention it again. We've got two pediatric-looking head CTs. Both of them are non-con. And the point of the case is to compare and contrast the calcification patterns. So on the red, you can see that there are calcifications that are centered around the ventricles, periventricular, you might call them, and then on the orange, they're primarily centered in the basal ganglia. So on that alone, you should be able to give the two main things that do this. But I'm also going to point out the fact that there's clear hydro on this guy too, which is the other thing that's helpful. So the ones that are circumferential around the ventricles is C for CMV, C for circumferential. It's also the most common being a word that starts with the letter C also. So CMV is more common. CMV is circumferential. And then the other one is the other one. Toxo is in the basal ganglia. Sort of basal ganglia sometimes, I think, maybe looks like an O. And also you may say that, there's a dilated ventricle could look like a circle as well. Would be a way to remember that. So CMV, more common, periventricular. It's associated with polymicrogyria, strongly associated with, or the most strongly associated with relative to some of the other torches, and basal ganglia, calx, and hydro for toxo. Here's another one, compare and contrast. And I'll tell you that this is a person who likes to have sex with male prostitutes without using protection, while at the same time experimenting with IV drugs from needles that he got out of a dumpster. And he also is good friends with Charlie Sheen. So, and Magic Johnson, played basketball with Magic Johnson. All right, so I'm hinting at the fact that this guy's got AIDS, right? So these are two different people, yellow and red. Both of them are immunocompromised, and I'm showing you FLAIR brain MR images. Let's just review real fast how did I know that. So we can see that the CSF is bright. Let's just look at this one here. So CSF is dark, so it's a T1 maybe. It's not a T2. But then if it's T1, white matter should be white, and it's not, so it's FLAIR. So T1 and FLAIR are the ones that you could get mixed up if you're not paying attention, because you just be, dark CSF. But remember, white matter should be white, so that's FLAIR. And we've got hyper intense signal. And let's look at the patterns here. So this one here has a very central and symmetric appearance. This one here is more peripheral. It's going all the way out into the edges. And it's more asymmetric, right? It's like bigger on this side than that side. So central and symmetric, asymmetric and more peripheral. This red one here involves the U fibers. What the hell is a U fiber? That's like these most peripheral fibers here. Like basically that's just saying that it goes all the way out to the edge. Now I'm not showing you T1, but I will tell you that the T1 is normal on this person and abnormal with like low signal there. So this is HIV encephalitis versus JC virus or progressive multifocal leukoencephalopathy, or PML. Now the difference also is that this one's common. It's common at least in people with HIV. In fact, it involves like 50% of patients supposedly get it. With AIDS, CD4 count has to be less than 200, which, as you probably remember from med school, defines AIDS. This guy over here is less common, and requires a CD4 count of less than 50. So he has to be more immunocompromised. So the common one is symmetric. Okay, that's how I remember that. And also because it's sort of a common thing, I remember that the T1 is sort of normal because, it's normal. What's normal? It's more common, T1 to be normal or abnormal. It's more common for it to be normal. So it's just a way to remember it. And then the other ones are the other ones. So, all right, moving on. Another person who's immunocompromised, and this guy has these looking things here, sort of these funky looking lobulated holes in his head, maybe filled with gelatinous material. And this is a post-contrast. I knew that because it was labeled. And you can see contrast in the vessels and stuff like that also, right? And we know this is a T1, one because that's what you do when you give contrast, but also CSF is dark, T1, and the white matter is white, so it's not flare, it's T1. So those things. So this is crypto. I used a buzzword for it. Mucoid gelatinous cysts in these perivascular spaces, and that's the classic way to show it on a test or on a casebook. The most common presentation is actually it looks like a meningitis, a basilar meningitis. But if you see basilar meningitis, and we're going to have a case of that later, I want you to think of two other things, not crypto, at least for the purpose of the test. Obviously, in the real world, leptomeningeal enhancement that has a basilar predominance can be a whole bunch of different things. But most common fungal infection in AIDS, gelatinous pseudocysts. That's what you need to remember for crypto. All right, so here's another guy with AIDS, and point out a few things here. One, we've got a ring-enhancing lesion, and that in itself could be lots of different stuff, right? But then when we look at the T2, there is a shitload of T2 hyperintense signal, way too much, right? Look, this thing's not even that big. Like, why would you have that much T2 signal abnormality? It's a lot of edema, right? It's a lot of edema. You may say that it's out of proportion. It's a buzzword, okay? And now I'm going to show you the diffusion, and before I show it to you, I want you to mentally run through your head and say, how is that going to be helpful? So, what restricts diffusion? Hypercellular tumors. Lymphoma is the classic one for multiple choice, but GBM, medulloblastoma can also. Acute demyelination can restrict diffusion, but we know that demyelinating lesions tend to have an open C or like a horseshoe looking thing, and if they show it to you, well, multiple choice, an acute demyelinating lesion is not going to look like that, right? It's going to be C-shaped, an open ring shaped. What else restricts diffusion? Abscess restricts diffusion. Classically, bacterial abscess. That's going to be an important thing to remember. Certain infections will restrict diffusion. Some stuff that I'll show later on. Stroke obviously restricts diffusion. Okay, so let's look. It's not restricting diffusion. So how is that helpful? Okay, so it's not a tumor, well, not a hypercellular tumor. It's not a stroke. It's probably not a hematoma. It really looks like, I told you this is a guy with AIDS, so you were thinking that it was an infection. You may get tricked, and this would be the reason to show diffusion on multiple choice, is to try to trick you into thinking, oh, it's not an abscess because abscesses have to restrict. Wrong. Bacterial abscesses restrict. Fungal abscesses or atypical infections don't have to. So this is toxo, and those are like the three things that are like the main things to know. Toxo, it's typically ring enhancing, person with AIDS, way too much edema based on the size of the lesion, does not have to restrict diffusion. Now I talked about this in a pulmonary lecture, I think, that thallium is going to be cold for toxo, and then lymphoma would be hot. Now, lymphoma would probably restrict diffusion also. And just a quick review, remember that thallium is a potassium analog, works on the sodium-potassium pump that requires active transport, ATP, so the thing has to be like a cell that functions like that like a tumor, lymphoma, whereas toxo wouldn't have that ATP sodium-potassium pump going, so it would be thallium cold. Let's do a rapid review here on these infections that we talked about. So PML, we said that was the asymmetric one versus HIV, which was symmetric. P for peripheral, and then C for the other one is central. Remember, HIV is the common thing. Common is central. U fibers because it's peripheral, and then no U fibers there. And then T1 dark versus T1 normal. Remember, it's normal to have this 50% of the time with people with AIDS have it, so that's how I remember the normal. Periventricular calx, it sort of goes circumferentially around the ventricle, C for C, versus basal ganglia calx and hydro. And then as an adult, you think about ring enhancement, no restricted diffusion, thallium cold, edema out of proportion to the size of the lesion. And then crypto, just remember mucoid or gelatinous perivascular spaces that doesn't necessarily enhance. All right, so next case. And we've got hydro here. I'm showing you hydro. That could be anything, right? And then the next case is this. So this is the skull base, or lower down, not quite the skull base, but basilar. And it's a T1 post-contrast. I'm showing you lots of enhancement, so too much enhancement. So this is our basilar meningitis. This is our basilar meningitis case. So when you see that, I want you to think of two things. One of them is TB, and the other one is sarcoid. So like they can have that kind of basilar leptomeningeal dural enhancement. So TB, actually the most common CNS manifestation is meningitis. You can get like focal tuberculomas, which are pretty much what they sound like. So think about those two things. Next case is another infection, of course, and what I'm showing here is what? What is it? Is that T1 or is that flare? So how can you tell the difference? Look at the white matter. White matter's dark, so that's flare. And we're seeing abnormal flare signal primarily in the temporal lobe. Looks swollen, right? Look at this part relative to here. Swollen, right? So a swollen temporal lobe. Right away, you should be thinking about one diagnosis. I'm going to show you diffusion. I'm showing you two slices, and I'm showing you these slices for a reason. One, I'm showing you that it does restrict diffusion, which should not throw you because herpes encephalitis, which you probably know is the answer to this case, classically restricts diffusion. In fact, that's the most sensitive sign. It's supposed to be the first thing that happens. But when we go up here, it's sparing the basal ganglia, because remember, we have a list in our mind of the things that restrict and don't restrict diffusion. I show you restricted diffusion. It could be a stroke, right? So how do you know it's not a stroke? Well, that's MCA territory. When you have an MCA territory stroke, it usually involves basal ganglia, and it's sparing it. So that is like a classic way to tell. I'm showing you, like, if stroke was in the differential, like as far as, choice A is herpes, choice B is MCA, infarct, large territory. The way to tell the difference is look at the basal ganglia, okay? They have to show you that. There's another thing called limbic encephalitis that can also give you like sort of a increased signal in temporal lobes, and that is a paraneoplastic syndrome, classically lung cancer. So if you get a next step question on that one, it's look for the lung cancer. But you'll want to next step, if a choice would be call the ER or call the floor or call the doctor. That's what you would want to do with this case, because herpes is sort of an emergency, right? It's got a high mortality rate, so they want to start them on antiretroviral therapy ASAP. So yeah, it's important to call. That used to be a thing with oral boards, was what will you do next? I would call the ER, blah, blah, blah. So you don't have to do that anymore. So that's your big next step thing. All right, next case. So Here is a gyriform restricted diffusion. So what the hell does that mean? It means the cortex is restricting diffusion here. See that? Look at that. Boom, 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 all the way around. A little bit maybe going up here stuff too. All right, so this is a classic way to show CJD, which isn't as uncommon as you think. And the classic look is cortical gyriform restricted diffusion. Another way to look at it is, or another way for it to be shown. So if I was a betting man, this would be the way that I would guess that somebody would show it to you. If I was forced to choose a second way to show it, it would be the so-called hockey stick sign, where this medial thalamus has the appearance of a hockey stick, a high signal there. And the third most likely, or the least likely way, the person who speaks the third most Italian, is a series of CTs or MR showing you rapid progressive atrophy. That's another thing. So as a piece of trivia question also, restricted diffusion is the most sensitive sequence. That's true with CJD and with herpes. And the protein assay that you would look for in the LP is this 1433 protein. Yeah. Family med or step 1 trivia. Okay, next case, another diffusion case, and you're sort of seeing this subdural looking thing that's restricted diffusion, and that is a classic way to tell you that there's a subdural empyema, fluid collection there that's infected. So, it's this stuff here. We can see dural and leptomeningeal enhancement, and corresponding restricted diffusion, so that's pus. Boom. All right. Next case. So if you could see it yet. See it? Oh, that guy right there. Calc, a little bit of sort of weirdness going along there. So be like, really? That's it? Yeah, that's it. So that's a way to show neurocysticercosis. Another way to show it is a bunch of holes in the head. Remember that it's eating contaminated pig stuff. Pig poop as the carrier or whatever. It's a parasite. Typically, involvement of the basal cisterns has the worst outcome. As it gets chronic, then that's when it gets calcified. So it has different stages. I talk about them in my book, but the thing that I think is the most high yield is the chronic ones are calcified, and the cystic ones that have a bunch of edema. That's what it looks like when it's in its acute phases. So if I was a betting man, really you could show it either way. A whole bunch of holes in the head, like punched out holes in the head, would probably be the most likely way it would be shown. The second most likely way it would be shown would be calcs, and probably more than one. Probably a whole bunch of different calcs. And they may tell you the guy's a Mexican pig farmer or something like that. That would be a good giveaway if you're lucky and you get any history. All right, moving on to some head and neck cases. So we've got a masticator space mass, and then an adult, the most common masticator space mass is an odontogenic abscess. Now, this particular odontogenic abscess is a special one in that it's got a bunch of gas in it. So when you see gas like neck fash in the face, there's a specific name that goes along with that, and that's Ludwig's angina. So it's basically neck fash of the mouth or the face. They have to show you gas if they're going to call it Ludwig's angina, and they usually start with a tooth infection. All right, another case. This is another odontogenic situation, and this right here alone you may not pick up, but when they show it on the bone window, so bone windows and this head are going to be shown for a couple of reasons. One, to show you lucencies and stuff in the teeth. Two, to show you fractures in a trauma situation. And three, to show you like aggressive osseous lesions, which should be like obvious. So this, when centered over the teeth, immediately look at the teeth because that's what they're going for. So 3 testable facts on odontogenic abscesses. One, the infection is actually more common from an extracted tooth rather than an abscess involving an intact tooth, which is sort of counterintuitive because you think that like once you pull it out of there you'd be better off, but it's not. That's not the case. Therefore, that makes it testable. The next thing is that, and I mentioned this before, in an adult, the most common mass in the masticator space is a odontogenic abscess. In a kid, you may be thinking about some rhabdomyosarcomas or something like that. It's less common in kids to have a mass in the masticator space. And then 3 is the way that these things locate and spread. So let's talk about that. So here's a mandible, part of a mandible, and there is this thing called the mylohyoid line, it's basically the attachment of the mylohyoid muscle to the mylohyoid ridge, which dictates spread of infection. So basically, below the second or third molar, you are going to end up with, and so if you have your infection there, you're going to end up with your infection draining into the submandibular space. And if you are, if you have an infection that is in front of that, then it's going to drain into the sublingual space. So that's testable. So that second or third molar is going to dictate spread. And if we look back at this case, I can't remember if it was submandibular or sublingual, but if you go back and rewatch the lecture, you can be able to distinguish between the two. It's irrelevant. I think that more than asking you by showing you the space, it would be more likely that they would say, this infection started involving the third molar, which of the following spaces would it spread into? And that's how you can tell the difference. All right, next case. So this is the thing that I actually forgot to mention also, is that another skull-based bone window thing is this right here, where they're showing you mastoiditis. So look at these things, normally aerated over here, totally opacified and like partial coalescent, so that's abnormal, right? And then I can show you that same finding on MR, where we've got diffuse enhancement of the petrix apex of the temporal bone, and that's super abnormal. And then if I show you this guy here, then you notice that he has blue eyes, one blue one way and one blue the other. So this is a guy who has Grandingo syndrome, which is basically when the apical petricitis involves Dorello's canal, which is where cranial nerve 6 is located. So they probably could show you an actual picture of a person, or they could tell you that the person has a lateral rectus palsy. So you have a classic triad that's otomastoiditis, face pain, usually trigeminal like neuropathy, face pain, and lateral rectus palsy. So that's the Grandingo's syndrome. And that would be shown in the setting of a petrous apex infection case, just like the one I showed. All right, so that's the end of our CNS infection talk. The next talk is a talk on the spine.